All right, well, I say we get started. So welcome everybody to our noon conference. Today we have a cold case, which will be discussed by Dr. Colton, who took care of this patient. The way the format works is we have resident discussants, Dr. Williams, Gardners, and Johnson, will be trying to work through the case and come up with a diagnosis, and I'll help facilitate our group here. So if the discussants want to introduce themselves and say hello, that would be great. Dr. Colton, I'll let you go first.
All right. Hey, everyone. I'm Meryl Colton. I'm an R2 here in the program. I'm originally from Colorado. I spent some time on the East Coast for undergrad and a master's of public health, and then came back for med school and love Colorado so much that I had to stay.
Jordan.
Howdy, howdy. I'm Jordan. I'm an intern here in the hospitalist tract. I'm originally from Bay Area, California, but I did my med school at Tufts in Boston. So now I've gotten to see both coasts and a little bit more in between. Super stoked about this program, and I hope you guys all have a great interview day.
Tiffany.
My name is Tiffany. I'm one of the R2s that's in the hospitalist track as well. I'm from Oregon and did med school at OHSU, and now out here, hoping for a career in hospitalist medicine.
Great. And then Thomas, if you're here, I'll let you go. Otherwise, we'll get you introduced when you're here. Okay, we'll give him some time to get on. And I'm Sneha. I'm one of the chief medicine residents here, currently at the VA, and then I'll be switching over to the university site starting in February. I was also in the hospitalist track, and I'm planning to be a career academic hospitalist. Really enjoyed my time here, and I'm excited to do this conference today. So let's get started. So, first and foremost, welcome to our applicants. We're thrilled that you are interviewing with Colorado. This is really a fabulous program, and we're really glad to have you here. You are coming from all across the country, and today we have a few international applicants as well. So thank you so much for joining today. This is an opportunity for you to see how one of our conferences works. And so sit back, relax, and enjoy. If you're interested in participating, feel free to throw your questions or comments in the chat. But we'll leave the discussing part to our residents who are our discussants today, since they so kindly volunteered. As far as our teaching structure goes, so when we're able to, when social distancing isn't a measure, we do all of our conferences in person, and we have fellows come and teach, chief medical residents do lectures, and so we have a really fun social time during those hours. Currently, we're doing a daily virtual conference, much like what you're seeing now. Even during COVID, when we were able to, we would hold small in-person teaching with masks and social distancing with 5 to 10 people, and we're hoping to get that restarted when we can. And finally, for those who aren't able to attend our conferences, we also have an active YouTube channel, which you can get to through that QR code, but we put all of our lectures up for people to view or review at their own time. So it's been going really well with that. And then for our residents, we set our Stump the Chief conference for February 5th. So be sure to be there. Jason John is going to try and stump us with a tough case, and we're excited for that. And then one last thing I wanted to talk about before we get started today was just a word about clinical reasoning. As I progressed from being a medical student to an intern to now a senior and then a chief, I really tried to wrestle with what makes a great clinician. You'll see today we have a couple of experts here, and anytime they chime in, I wonder, well, why couldn't I have come up with that? They always have really great insight. And so what I would propose is that a good clinician does deliberate practice and listening. So if today all you do is just listen to how others reason through a case, you're gonna progress. Great clinicians ask questions, but exceptional clinicians ask questions with the why. And so, for example, if you're discussing a young patient with a GI bleed, you can ask, well, what's the family history? But if you're taking it next step further, you can ask, what's the family history? And I'm asking because I'm wondering about Lynch syndrome in a patient with GI bleed that's young, right? So today I would encourage you all to try and add that why when you ask your questions. With that, let's get started. I'll let my co-chief Danny take over the screen here.
And should I start, Sneha?
Yeah, Meryl, go ahead and get started. So tell us what's going on with this patient.
Yeah, so we'll just kind of start with kind of the opening one-liner. So we picked up in the morning a 55-year-old woman, and she has a history of HFpEF, of non-sustained VT, OSA on CPAP, and alpha thalassemia, as well as bipolar disorder. And she was sent in for pre-syncope and hypotension.
So let's leave the rest of the history aside for a second, and for the discussants that are here, that is a lot of information just from the one-liner. And so based on the chief complaint and that information, what are some thoughts that immediately come to the top of your mind?
I'm happy to start. First, when I see a chief complaint of dizziness, I try and divide it into whether or not we're talking about vertiginous symptoms versus kind of pre-syncopal symptoms. Some people will describe dizziness as being lightheaded versus having the room spinning around them and they're going to fall over. In this case, we have a 55-year-old woman with the history of several cardiac issues coming in with what is described as pre-syncope and hypotension. So certainly leaning towards the syncopal side of things. And then when you activate your syncope kind of schema, I first tend to think about 4 causes of kind of things that could look like syncope, including the mimics like seizures, hypoglycemia, strategic strokes. And then when you get to true syncope, I tend to think about orthostatic causes, causes that are related, that are vaguely mediated, including stress or carotid hypersensitivity. Then you think about cardiac etiologies that include valvular problems like aortic stenosis, having kind of obstruction with tamponade or a PE, and then electrical causes. And then kind of there's other categories that might include neurogenic causes of syncope, but those are usually pretty rare. Now, certainly with this kind of background history, you would be leaning towards a cardiac etiology, probably particularly a electrical one is my guess, especially if they had this history of VT. But we don't want to prematurely close, and so we'll kind of keep the differential broad. And then we certainly need to look at this concern of hypotension. We'll want to be getting blood pressures in both arms, doing orthostatics, doing a volume exam.
Jordan, that is fantastic. So what I'll do is let Meryl answer some of these questions in real time so that you gather more information. So Meryl, go ahead and answer some of those questions.
Yeah, really excellent, Jordan. I would have expected nothing less. But I agree, really important to kind of differentiate, is this I'm standing and the room is spinning, or do I truly feel lightheaded? For her, it was very much lightheaded. She was actually rushing to another appointment at National Jewish that morning and skipped her breakfast and her morning pills and really just felt lightheaded. And then other questions about, should I just give the rest of the history maybe?
Yeah, I think Meryl really, like, she has not had true syncope. She's felt this pre-syncope, but she hasn't actually passed out. That's important.
Exactly.
And then let's give the rest of the story there as well.
Yeah, so like I said, she was rushing to her appointment at National Jewish this morning, hadn't eaten, and then was in the elevator and sneezed. And then right immediately after that, after she got out of the elevator, she felt really lightheaded and dizzy. She felt nauseous and she felt weak, like she was going to pass out, but she never actually passed out. She said that it only lasted for a second. The people around her thought it lasted for about a minute. And then when she checked in for her appointment, her blood pressure was 75/50. So they called an ambulance and sent her to University Hospital.
Great. So I'll let you all take a second there to let all of that sink in. And in the meantime, I see that Thomas is here. So Thomas, would you mind introducing yourself so everybody knows you're our third discussant?
Yeah, sorry I was running late, guys. Was getting my car work done this morning. But I'm Thomas Johnson. I'm from a little north of Los Angeles, but went to all my schooling in Texas. And then I'm a third year in the residency program here. I'm in the primary care track, and I'm going to stay on for geriatrics fellowship next year. Super excited. So I'll get to meet a lot of y'all on your acute care for the elderly rotations and geriatric rotations.
Thanks, Thomas. Perfect. All right, Tiffany or Thomas or Jordan, any more thoughts or any different ways in which you're thinking about this case now?
I think Jordan said most of the things I would think about. He didn't leave a lot less to say, but I am, with her history of NSVT, I am thinking about arrhythmias. And then because she had this episode right after she sneezed, I am more concerned about like a vaguely mediated event.
Great. And then just to sort of round out the history, since you guys have really focused on sort of the cardiac etiology, we don't have any records in our system. She hasn't been to UC Health before, except for she just established with a new primary care family physician through UC Health, and they were able to obtain some of her cardiology records, which are from National Jewish. And it essentially says she's just only had one episode of SVT, or non-sustained VT that happened during a old hospitalization. She saw an EP doctor with them and and is on a beta blocker, which she's supposed to continue. And then has also had a recent stress test as a result of that, which was normal.
I think there's a couple other things that I would probably comment on. When you're thinking about pre-syncope, you think about not getting enough blood flow to the brain and remembering that you have multiple sources of vasculature that are going to supply your brain. But again, localizing to the heart and what's going to promote enough cardiac output to support that, you can think about heart rate times stroke volume. So whether or not it's going to end up being a stroke volume issue or a heart rate issue, are there going to be any sort of other than tachyarrhythmias, bradyarrhythmias that we could be thinking about? If it's stroke volume, or is there a preload issue? We have to think about medicines. You mentioned the beta blocker. There's other medicines that will impact our heart's capacity to respond to exercise, for instance, or might impact the vasculature in terms of its capacitance with blood. So I think we have to do a good med rec as well with this patient.
So let's do it now.
Yeah, so the patient lets us know that she is taking albuterol and budesonide formoterol for asthma, and some notes also mention asthma/COPD. She's on atorvastatin 20 from that same cardiologist, metoprolol succinate 25, and furosemide 20 milligrams from that cardiologist. And then she takes ezetimibe for hyperlipidemia and ibuprofen and lidocaine patches for some low back pain.
Jordan and Tiffany are doing a great job so far. So I don't have a lot, and I'm not surprised. Tiffany was one of my wonderful interns, and so is Meryl last year. Now they're amazing residents. I think one thing that's interesting, I'm always interested in the history and the story, especially in syncope or pre-syncope. And so what's really interesting to me is the fact that she missed her medications and then also missed breakfast, because that can narrow down, based off of Jordan's differential we had earlier, that can help us think through this a little bit better. Obviously, we have a lot of cardiac concerns for this patient, but even with missing breakfast, could we be missing some weird, endocrinologic cause of this, hypoglycemia or anything like that? Obviously, I think most likely cardiac, but I don't want to narrow things down too quickly.
So Thomas, I think that's an excellent point. And so how could you maybe help differentiate whether this is cardiac versus endocrine? What other questions about her HPI can help you clue into that?
Yeah, so I think with the hypotension on presentation is important, but it's not too different from her baseline blood pressure. But that is important. With her VT, we have to think about that more. And I like how we were talking about cardiac output being dependent on heart rate and things like that. I guess I can't remember the eponym. If you want to think about hypoglycemia, there's the triad of symptoms that you can think about if this patient always experiences dizziness after missing meals, things like that. And it's always reproduced by those. I can't remember the name right now off the top of my head.
Okay, great. And then one other comment that I would make is we won't specifically go into a review of systems here, but looking at the patient demographics, are there any specific questions that you would ask on that to obtain some more history for this woman?
Sneha, I don't have a question about her demographics necessarily, but one thing I am curious about is like why she missed breakfast. Like, has there been like a couple days of general malaise and she's been taking her Lasix and then this morning missed meals and skipped her medicine? Like that could cue me into like, is she really volume deplete or is there an infectious process going on that might affect her volume status, or really just if she hasn't been eating because of some other process?
Yeah, that's a really good question, Tiffany, and something we asked her. Turns out she's been feeling pretty crummy for a while. She's going to that doctor at National Jewish because she's been also having dyspnea for a really long time. It's had asthma and COPD and feels like it's getting worse. But she says that she's been just feeling overwhelmingly tired for actually many years now. It was probably like the last 10 or 12 years that she's just been feeling like exhausted all the time.
Are there any other localizing symptoms like palpitations, other systemic things going on?
No palpitations.
Constitutional symptoms,
No
cough.
weight loss. She has an intermittent cough,
Yeah.
but she doesn't feel like it's worse now than it's been.
I guess with prolonged fatigue and like general malaise, and it looks like at least chronic borderline hypotension, I would worry about adrenal insufficiency. Doesn't look like she's on steroids, but she could have other causes of adrenal insufficiency.
I think this is a really. Oh, sorry, go ahead, Jordan.
Oh, no, after you, Dr. Connors.
No, you go.
I was just curious, no diabetes history?
No diabetes.
Does she have frequent COPD exacerbations that make her take steroids?
She has, she does say she has a lot of problems with breathing. It's hard to know because we don't have any records from her. And she doesn't think that she's been hospitalized a bunch for COPD.
All right, Meryl, so I'm going to have you give them the social history and then let's get into the vitals and exam here.
Great. So not a ton of medically relevant social history, but super sweet lady. She lives alone and currently doesn't work. Says it's been hard for her to find a job in the last even 10 years. She has 3 children. Her last one was born in 2006 when she was 41, and she doesn't smoke. She rarely uses alcohol and no drug use. And then in terms of vitals, she was afebrile when she came. Her heart rate was 57. Like we said, blood pressures on initial presentation were 82/47, but improved to 90/58 after just 500 cc's of fluids. Rest rate of 13 and satting 93% on room air. In terms of her exam, she's an obese, well-appearing woman. She's a little bit congested and has some rhinorrhea. In terms of her pulmonary exam, she was cleared to auscultation bilaterally. Cardiac exam, she's sort of distant heart sounds, regular rate and rhythm, no rubs, murmurs, or gallops. Abdominal exam, non-distended, non-tender to palpation, all 4 quadrants. Her skin is warm and well perfused, no lesions or rashes. Neuro exam, cranial nerves 2 through 12 intact, no focal neurologic deficits. And in terms of psych, she's a little slow. Like there's kind of some pauses before she responds. And it was a little bit tangential, like you're asked her something and she'll go kind of talk about something different, but otherwise no pressured speech or anything else notable.
Okay. So what I want to do is we have Dr. Connors, who's our program director. And so I'm wondering, Dr. Connors, thus far, tell me, somebody with your amount of experience, how you're looking at the case.
Yeah, for sure. Thanks. I'm happy to. I love where you're going with this. I also find syncope / pre-syncope one of my favorite things to work up because it's complex and defined. And so I agree with what Jordan and others are saying. I think about this being an issue of oxygen delivery to the brain. So we say blood flow to the brain, but what we're really talking about is carrying capacity. And so the fun thing for Jordan is you can go back even beyond the cardiac output and think about the delivery of oxygen, which includes cardiac output and the content of oxygen in the blood, especially your pre-syncopal symptoms. And so that gets at your causes of anemia, things like that. And then I think the question is this low oxygen delivery to the brain because it's just not getting to the brain, like some sort of a bilateral carotid lesion, or is it low delivery to the brain because it's not getting to the entire body? And I think her symptoms are leading us to think it's not getting to the entire body. And then that's going to open up those adrenal causes you all talked about. It opens up infectious causes. Could this be sepsis? I mean, this is not a great story for that, but just thinking broadly as much as possible. So I really do enjoy this differential diagnosis. And then when you do go, down the cardiac pathway, and I like to use the question mark of syncope, you've got mechanical and electrical causes, obstructive and underfilling causes for the vessels, migrainous and vasovagal causes for the brain. It really allows you to have a nice framework to work through what is otherwise a pretty complex problem.
Great. Thank you for lining that out for us, because I think often what we forget to do is go back to like the very pathophysiologic basics. And so I love that the way you're thinking about it is the main problem here seems to be oxygen delivery to the brain, and then is it versus oxygen delivery to the whole body. And so I really love that approach. And so for our three discussants, we will give you the basic labs that we get on most of our admitted patients. But are there any other special studies or labs that you're thinking about getting essentially on day one or on admission?
You said other than the basic labs, Sneha?
Yeah, we'll give you like the BMP, CBC.
I'd probably want a BNCP, a TSH, at some point I probably would want a cortisol.
Okay, and Tiffany, how are you going to obtain that cortisol?
Probably a morning cortisol.
Okay, fantastic. What else? Anything else?
I'd probably try to get a better sense of what her volume exam is before I got to labs. Like, are her mucous membranes moist or hyperpigmented? And it doesn't sound like she has any edema, right? Okay.
She's like totally euvolemic, let's say.
And no extra pigment, moist mucous membranes.
In the kind of ED mindset, I can't remember if you said chest X-ray, EKG, and then a lactate, just to make sure we're not missing something else.
Fantastic. Okay. Go ahead.
I was going to say, going back to like the physical exam and vital signs, I think this kind of supports Dr. Connor's hypothesis that there's probably something else systemic going on. I do find it interesting, like her heart rate's still like 59, and I guess she wasn't taking her beta blocker. She isn't febrile, so kind of less likely an inflammatory thing. I can't see the rest of the vitals right now, but not anything too surprising there. Her cardiac exam, I think, is notable, that there wasn't any special findings there. I don't know, there's just making sure we're paying attention to the physical.
Yeah, I think her bradycardia is definitely inappropriate. I love POCUS, so I'd probably put a probe and make sure she doesn't have like a pericardial effusion, because I can do that very quickly.
That's a great humble brag, Tiffany. I love it.
Just trying to like let people know we just work with here. Applicants.
All right, let's give folks some of these labs.
Great. So in terms of the CBC, the white count was 5, hemoglobin 8.5, platelets 244. And again, we don't have records from her, but some records from about 8 years ago at Denver Health say her hemoglobin was around 9 then. In terms of her basic metabolic panel, sodium 143, potassium 3.9, chloride 107, CO2 27, BUN 15, creatinine 1.22. Looks like baseline is closer to 0.9, and glucose was normal.
Oh, that low voltage EKG.
Yeah.
Want to roll out that?
So we did get an echo. Let's show you that.
Great. So the echo just had LV was normal in size, proximal septal thickening noted, presence of left ventricular diastolic dysfunction is indeterminate, EF of 72%.
So normal.
Normal, yeah.
Mhm.
And then, yeah, the TSH was normal, A1C was normal. She didn't get any imaging. Like Tiffany said, the EKG was normal, but just low voltage. And then the telemetry overnight when we came in the morning had no VT or other arrhythmia.
Hey, Meryl, while she was being observed and having her tele recorded, did she have any similar symptoms? Like, can we say we saw this thing on monitor, or was she just in her otherwise not perfect usual state of health?
Just in her otherwise not perfect state of health.
Okay, thanks.
Yeah.
Meryl, did you say we didn't know what her baseline kidney function was?
Closer to creatinine of 0.9. So she's got a little AKI.
And then how about her hemoglobin? What's the baseline for that?
Yeah, and that was tough because we didn't have any records in our system, but we could see from like a Denver Health record from 8 years ago that it was somewhat closer to 9, so not too far off her baseline.
Just kind of going back, it's kind of interesting, you know, the low hemoglobin has this history of alpha thalassemia, so it might be expected it to be low, and also has this history of lung disorder, so maybe that would have confounded it and bumped her hemoglobin up a little bit if she had greater stimulus. Looking at her BMP, I'm not seeing anything crazy other than this creatinine. I find the EKG low voltage interesting, especially with this history of the abnormal SPEP, UPEP. It certainly evokes from me like a thought of amyloidosis for some reason. That's just kind of a random association I would have. And I think it could potentially tie together a lot of these things.
Yeah, Jordan, I love that you said that because as a future hemonc person, I was like fixated on this. I was like somebody with low blood pressure, and she had like some proteinuria on a previous clinic visit, and the SPEP and UPEP were normal, but they hadn't gotten kappa, lambda, free light chains, and I was definitely interested in that as well. Let's go back to her hemoglobin real quick though. Is there any questions you guys would want to ask in a 55-year-old who's coming in with hypotension and a low hemoglobin? You're not sure if it's acute or not.
And the reason Meryl is asking this is because this is something we frequently don't ask this population and is very important to think about.
Oh gosh, no, I think I'm thinking of the wrong thing, but I do think I would ask about if she's up to date on her colonoscopy, just any one that could have a GI malignancy that has anemia.
Yeah,
Good.
And especially.
Go ahead, Meryl. I'll let you go.
Yeah, like we always think of this because everyone has a colon that needs to be scoped, but especially for older women, what should we be asking?
I mean,
she's still having menses.
Yeah.
And then along those lines, where else can a woman bleed? And bleed quite a bit.
you can have hematuria too, I think.
Yeah, we're sort of guiding you guys to ask about
Vaginal.
abnormal endometrial bleeding, right? So abnormal uterine bleeding, if they're still having spotting occasionally or having what she thinks might be periods, but in a typical woman by age 55, most women have hit menopause. So important to ask about that. So Meryl, why don't you tell us a little bit about that story, and maybe that'll put the pieces together here for our crew.
Yeah, so I sort of push you on that because this sort of reveals a lot about the case. But essentially, when we ask her, if she's having any abnormal uterine bleeding, she mentions that she actually hasn't had a period in 12 years. Since the birth of her last child, she never had a period, and that was at the age of 41. So does that make you guys think of anything?
Did she have like a pituitary apoplexy event for some reason? I mean, I think that's premature. Typically menopause average age is 51, and I'm forgetting the cutoff for what exactly premature menopause is. But if this happened after, let's see, blah, blah, blah. Sorry, when did her last baby in 26? No period.
It happened right
So
after her last birth.
Yeah, so that certainly makes me think of a pituitary apoplexy event, which could certainly account for having some panhypopituitarism leading to lots of systemic symptoms that we're seeing.
Yeah, and are there any other labs that you could get to help you test that hypothesis?
Tiffany mentioned one already, which was the AM cortisol. And it was drawn at 3:24 a.m. So that's not necessarily the 8 a.m. cortisol that we love, but that was one. And that's extremely low.
Can I bring up something about that? I think AM cortisol is always interesting because I remember when I was an intern, we had a patient that had that was in the ICU in shock with like a not decreased AM cortisol. So the team kind of shut off their thought process of endocrinologic causes, but then it ended up being on the court stim, there was like no stimulation that was possible. So it's important that an AM cortisol is a great screening test. If it's super low, then something's happening here. However, if it's even close to the moderate range or elevated, it doesn't tell you quite as much. If it's over, I think, I can't remember what it is, 18, then it pretty much rules out an adrenal insufficiency.
Nice, Thomas.
You would expect an AM cortisol to be elevated in the setting of shock. So the fact that it's like inappropriately normal should make you want to stim that person.
Excellent. So let's give you guys some of those endocrine labs. And we'll get into some formal teaching.
Yeah. Great, guys. So I think what was first notable to me, we immediately thought about the pituitary. But the first thing that we got just to screen it out was the TSH, which we had got just add on from the night before, and it was normal. And so we went ahead and court stimmed her. And as you can see, the court stim baseline was 2, after 30 minutes was 6, and then only got to 10. So something was wrong. And so then we went ahead and took the thyroid a step further and got the T3 and T4, which were grossly low. And then went ahead and ordered an LH, FH, prolactin, which were all grossly low. We got the kappa lambda, Jordan, which actually came back normal. And then her vitamin D was low as well.
Great. So what do you guys think is the diagnosis?
Panhypopit.
Fantastic. Yeah. So let's learn a little bit about that. And we actually have 2 endocrinology experts here. We have an endocrine fellow, Jill, and Jill Wagner, Dr. Wagner, and then Dr. McDermott, who is one of the endocrine attendings. And so what I'll do is I'll just get us started here with our objectives for today, which were to reinforce the temporal nature of illnesses. And so I think I was trying to guide you guys here during the case, but to really remember when you see a patient like this, if a patient who normally runs in the 160s for blood pressure and drops to the 90s, they're going to have acute symptoms, or a majority of them will have acute symptoms. But in this woman who at 90s seems okay, maybe some mental changes, it's important to ask really the temporal nature of her illness. And once we learned that this had been going on for 12 years, she hasn't had a period in 12 years, we sort of start to put together the pieces that this is a chronic condition, which led us to sort of this endocrine route, right? We're going to talk a little bit about hypopit workup, in which downstream hormones are affected, and then we'll outline the basics of treatment here. So just basic anatomy here, the pituitary gland is one of those glands that we can pick out on imaging, even as internal medicine doctors. And so that's where it is, sits in the sella turcica here at the base of the brain. When it's blown up, you can see the stalk, you can see the anterior pituitary, and then the posterior pituitary, which is normally a bright spot. And you can see that in this image here as well. They think the bright spot happens because vasopressin is stored in that posterior pituitary, and it's just the way it lights up on an MRI T1 weighted image. I love to talk about etymology, and so a side note here is when the pituitary was first discovered by Galen, like way back, they thought that it was a mucus secreting gland, and that's where our nasal mucus comes from. And so now when we say pituitary gland, it's really just a historical measure to say it, but it's no way accurate. Anatomist Sommering described it as the hypophysis, which means undergrowth, and so that's more appropriate on how it sits in the brain. He also called it the appendix cerebri, which I think is really a cool name for it, and I might throw that in there with my teams in the future. I thought that was really cool. Not to scare you with this diagram, but I think the endocrine system is a really elegant logical system. And so the way the pituitary works is there's anterior and posterior components. Posterior we won't talk about today, but it produces two hormones, oxytocin and vasopressin. We'll be focusing on the anterior pituitary today, which is normally the side of which is affected during panhypopit. And as you may recall, the anterior pituitary produces many hormones. More commonly, ACTH is affected, but any one of these can be affected. And so in panhypopit, we're typically talking about these hormones being out. And so I wanted to invite our endocrinology colleagues to help us sort of work through how they think about a patient that may have hypopituitarism, and how should we begin our workup. And I think the main questions would be, should I always cord stim this person, or do just the cortisol and ACTH tests give you enough information? So I would love for Dr. Wagner or Dr. McDermott to sort of talk us through this workup when it comes to the HPA axis.
Sneha, this is Mike McDermott. I just want to thank you for inviting us. All three of our fellows wanted to be on, so we have Jill Wagner and Aaron Finn and Rebecca Jeffers, so they may all kind of chime in here.
Fabulous. I have a few slides where I have questions for y'all, so you can each take one.
Can you guys hear me okay?
Yes.
Cool. Okay. So I think that you guys hit it on the head to say that the first round is always that AM cortisol, and that'll give you kind of a way to decide where to go next. Someone had mentioned that you see kind of inappropriately normal cortisols in patients, and so we kind of deal with things when they're absolutely low, when they're inappropriately normal, and then when they're appropriately stimming high. And so in this case, her AM cortisol was 1, and kind of by our standards, anyone that has a 2 or less, by definition, that's never an appropriate amount of cortisol. So it will always be, you don't even have to do a stim test in that case, because a 1 or 2 value, even if it's me, like not even stressed to come to clinic, I should have a higher cortisol than 1 or 2. So anybody who has a 1 or 2 that's not on exogenous steroids, or a reason for it to be that low, automatically is then qualified as adrenal insufficiency. So people for our center, anyone between that 3 and 18 is that intermediary range. And so if someone is just chilling, waiting for placement, that might not really tell you that much information, but someone who's coming in and they're actively first day of admission, acutely stressed and ill, that would be potentially an inappropriately normal or inappropriately low-ish cortisol. So those people typically get these cosentropin stim tests. And then it kind of depends on where you read. Greater than 18 is definitely an adequate response. Usually greater than 15, as your slide says, is okay. Sometimes some people read that if it's a greater than 12, it's fine. So it just kind of depends on the clinical scenario and what resource you're looking at. And so those intermediate folks are the ones that should get this stim test. And I wanted to make sure that I drive home the point that a lot of times people get steroids as pre-op, as, for lung reasons. Anything pulmonary, anything that might get steroids could cause this to be artificially low. So just keep in mind, if somebody has an AM cortisol that's 1, just make sure that there's no reason it should be low, as in I accidentally flooded them with a ton of steroids and drove down their HPA axis. And so typically what we see is either a doubling of the cortisol level with a cosentropin delivery, or at least get it higher than 18 as of the 1 hour mark. If at 30 minutes somebody's is 26 and it stays at 26, that's still an adequate response. And then further, kind of, some people have asked the question of, does somebody have relative adrenal insufficiency? Does that mean that, oh, they should have responded up to 30, they only got up to 18? Does that mean that they still don't have enough? And that's kind of still a questionable area that we don't know a ton about. But for your guys' purposes, if it goes greater than 18 after that stim test or as a random, that's an adequate response from their adrenals. Does that part are there any specific questions about those things? I don't see anything in the chat, so I'll just keep going, I guess.
Jill, I have one question for you.
Yeah.
You mentioned the steroids might skew this test. How much or how many days worth of steroids does a patient have to actually mess up your stim test or your baseline cortisol level?
They need like a single dose.
Just
So if somebody gets, so especially if it's within a certain number of half-lives of the steroid, like if someone got prednisone the day before and it was first thing in the morning, it will probably have washed out by that morning. But if they got Dex in the last 2 to 3 days, it will suppress this. So if anyone's post-op, anyone that has gotten it, I would say within 24 to 48 hours, it can't be trusted and you'll have to repeat it.
Excellent. And so just to round everything out for our teams here. So as you guys see, this patient's stim test doesn't hit the mark that we want. It's still less than 18. And so we're worried that this patient has adrenal insufficiency. And then her ACTH level was only 8. And so that's also very low. And so confirming that she had secondary adrenal insufficiency due to her OPID.
One thing that I'll add to this, and I know my co-fellows can attest to this too, some of you might be wondering, well, why didn't she stim? Is that a question? I mean, maybe this is past you guys, but when somebody has primary versus central adrenal insufficiency, you can kind of think of them in different mechanisms. So when it's primary adrenal insufficiency, meaning the adrenals are trashed for whatever reason, whether it's TB that somebody mentioned, hemorrhage into the adrenals, your stim test will not go appropriate. It won't be able to stim appropriately. In those cases, people often have hypotension because your aldosterone axis is also affected. Okay, remember the GFR of the adrenal gland? All of those get knocked out when it's primary. Secondary is actually the fact that you don't have any CRH, you don't have this ACTH, which is why measuring this is helpful, because if that's low, means that that's inappropriately low for the condition of the cortisol level. But that one shows up differently symptom-wise. So in that case, if it's the pituitary that's not working, your aldosterone system should be intact. So with central adrenal insufficiency, you don't really see the electrolyte changes, the hyperkalemia, and you don't as often see the blood pressure changes because your aldo system is fine. So in her, she's unique. Why did she do that? Because over time, it's a very use it or lose it system. So the ACTH actually makes a stimulatory effect on the adrenal glands. So if it's constantly seeing that hormone, it'll stay active. But she's had 12 years of no ACTH basically. So her stim test didn't stim appropriately because her adrenal glands are starting to atrophy because of lack of ACTH hormone. So that is why, in case you guys are wondering, well, why this looks exactly like primary, in her case, it's chronic central. So that's why this is a really cool case for us, and why it's that little nuanced change.
Excellent.
Okay.
Thank you. Yeah, that's great. So the next axis I wanted to talk about was the HBT axis. You know, as Meryl mentioned, the TSH here was normal. I was reading that at times TSH can be normal with pan-hypo-pit. And certainly with such low T3 and T4, your pituitary should be producing more TRH and therefore more TSH. And so I would say this is inappropriately low. But how do you think about this system? And just give us a little bit more information about the HBT axis.
Okay, sorry. I was trying to type to somebody back and then I was a bad house officer and I forgot the question.
Oh, just the question is, how do you think about the HBT axis when it comes to pan-hypo-pit, and how often do you see a normal TSH?
Okay, so I guess my question to pose to you guys, I know that's not quite interactive, I guess, but would you consider this a normal TSH? So it's technically an abnormal TSH, but you don't know that until you see the T3 and T4, right? And so the pan-hypo-pits, any pituitary source of hypothyroidism will always fool you if you only stop at the TSH, which actually kind of sucks because we tell you guys, please use TSH. And so it's frustrating from your guys' standpoint because you'd think, great, we're done. But in this patient, she had pretty classic, for me, I guess, classic hypothyroidism presentation where she's had chronic fatigue. Her heart rate was only 57. She's got all those cardiac issues, so maybe would have expected it to be a little higher. But you can't always trust the TSH because knowing the rest of this data, it's inappropriate. And so really anybody that has had pituitary surgery or apoplexy, you kind of use, you throw the TSH kind of out the window from that point. And so when you guys get like TBI patients, anyone else that has like chronic seizures, things that make you question, is that TSH in any way not accurate? It's completely reasonable to check a T4. A free T4 is ideal because it can give you that extra information. And once you know that they're skewed, you don't really go back. So then from there, you would treat them to a T4 level as opposed to focusing on that TSH. The fact that her TSH is there doesn't really tell you if the pituitary is working or not, because it's always going to produce a little bit. The fact that it's dysregulated is the more important piece. So don't think that, oh, her TSH doesn't work, it should be 0. It's more that it's dysregulated is the bigger issue.
All right, so just to not forget about our other HP axes, remember that there's the HPG axis, right? The hypothalamus pituitary gonadal axis. Here's a female version. In men, this produces testosterone, and so low libido is how it presents in men. For postmenopausal women, this axis is sort of not as much a factor, but that LH and FSH will be inappropriately low. Remember that growth hormone is another one of the hormones that comes from this axis. And in adults, once they're fully formed, it really is in a major way regulating gluconeogenesis with the liver and a little bit with muscles and adipose tissue. And then finally, remember that prolactin is also secreted by the anterior pituitary. And the way in which this presents with hypoprolactinemia, it really has to do with postpartum lactation. And so often with hypoprolactinemia, women will not be able to lactate. So I wanted to let us get to some treatment questions that I have. And so for treatment approaches in this patient, the first question is, sounds like this patient needs both thyroid hormone and cortisol replacement. And so when would you consider stress dose steroids before starting levothyroxine?
feel like I'm talking a lot. If either of my co-fellows want to interrupt me.
Sure, I can do it. In this patient, absolutely. So one of the things, when you have someone who's profoundly hypothyroid and you start replacing, I like to think of it as, so I'm Erin, I'm one of the other fellows. I changed my name, so when you're thinking about thyroid hormone replacing it, it kind of revs up the system. And so it can actually precipitate or worsen adrenal insufficiency. So if you guys ever call us about like the extreme hypothyroid myxedema in the middle of the night, we'll always say, are they at risk for adrenal insufficiency as well? Check a cortisol. Do we think it's, could they be concomitant? Because if you treat hypothyroidism before treating adrenal insufficiency, you'll make the patient worse. So you always stress dose. Well, you can get the labs and stress dose before starting levothyroxine. So good to remember that.
That's what was done in this patient, was starting stress dose steroids, some IV levothyroxine, and then she was transitioned to prednisone and levothyroxine.
Did I admit this patient? I think I did.
I think
one in three chance, Jill.
The next question I have is, in a postmenopausal woman, how do we manage the HPG axis, or do we need to? What should we do?
So, in my mind, it depends on, when postmenopausal. So if this had been caught when she was 41, and you say, oh, this could be, maybe it was caught at 45, and we're like, we just thought you went into early menopause. In her, I might argue we should give her 5 to 10 additional years of estrogen, probably estrogen with progesterone to protect the uterine lining. And that is from an osteoporosis standpoint. Once you're actually, post 50, 55, then you wouldn't necessarily do any hormonal replacement for the HPG axis in women. I don't know if you're going to have a men's one next.
I do not have a men's one.
Okay. So in men get a free pass in life. Their hormones are the same throughout ish. Older men don't need a testosterone of a 20-year-old, but besides that, we do tend to do hormone replacement of men, even into later years of life. Bones, it's good for, but also muscle preservation and things like that. So men will get replaced later in life on their HPG axis. Women will not necessarily.
Excellent. And then the last question I have is, we sort of talked a little bit about technically her secondary AI shouldn't interfere with the RAS system, but she does have this low blood pressure. Should we treat her with a mineralocorticoid as well?
So I'll answer the chat one first and then go, I would get a DEXA on her because she is short a number of years. And so she is at risk for osteoporosis. So you would do a DEXA, even though she's 5 years until her DEXA is due. But I would not necessarily treat her with estrogen for the bone. For number 3 though, I'm a purist. I would see how she responds with treating her actual underlying things we know before messing around with fludrocortisone and all that. And the truth is, even some people, don't hang your hat on it. Our system's resilient with the mineralocorticoid, and we eat a lot of salt in our culture. And so the truth is, a lot of people don't necessarily need the fludro, but in her, I would definitely treat the other things that we know she has before messing around with fludrocortisone. And if you stress dose or hydrocortisone for the first few days, it actually does have some mineralocorticoid.
Right.
And then prednisone replacement dosing has less, but that's all I would do would be prednisone at replacement.
Great.
I think that's what we did.
Cool.
If this was my patient, I think it was her. I feel so bad. I don't know her name.
HIPAA. It's built-in HIPAA.
Yeah.
Hey, Sneha, before we leave, I love listening to the fellows talk about this. And so for any of the fellows or Mike or everyone's, why did she show up 12 years later? Like, why not 7 or 3 or 6 months? Why 12 years?
Dr. Connors, I can answer that. We left that out of the talk, but this patient had all of this workup already done in 2012. She was on levothyroxine and prednisone and then just stopped taking those medicines, sort of out of the system, came back and didn't remember any of it. So it was essentially a sort of a brand new workup for the team when she represented.
But even at that point, she'd made it 6 years before she got her initial presentation, it sounds like. Is that usual for the endocrine folks?
central pituitary. So it's always good to remember, whenever you say hypopit or panhypopit, the truth is you really need to go through and say what is, because people will knock out one, but not the other. And sometimes people can knock out one and then the next and then the next. So it's always good. And the truth is people tend to eke by better with central adrenal insufficiency than primary. They're a little bit more resilient. Their system's working a little bit, and sometimes it's the stressors that push them over. But versus, Addison's, they crash a lot more frequently. And I don't know if Jill or Dr. McDermott have.
Yeah, and I think she had maybe an instigating event that she had pregnancy, and then maybe limped along and thought she was fatigued from that. And then it just kind of became, yeah, I'm maybe a little more tired than yesterday, but I don't know. I haven't compared myself to 6 years ago. So I think she just, over time, all these hormones washed out slowly. Like the adrenal insufficiency was worse with her blood pressure slowly, because she even said, my normal blood pressure is 90/50. So I think that it just happens sometimes so slowly in some of these high risk things like the TSH and adrenal insufficiency that people assume it's the new normal, as opposed to if someone had a massive worst headache of their life and they had sudden apoplexy from a non-trigger, they would say, I feel way different from last week. So I think that maybe is more so what happened with her. But yeah, I would have hoped she would have known that she had felt so bad, because she now feels probably way better.
Yeah. Great. Well, I've listed some other causes for hypopit that patients have. Apoplexy was mentioned, surgery and radiation and trauma are others. Sheehan, as we saw in this patient, and then just remember it can be autoimmune, and patients that are on immunotherapy with ipilimumab and nivolumab can sometimes get hypophysitis as well. Couple more things I wanted to talk about, just the healthcare disparities with pituitary diseases. So when it comes to surgeries, Black and Hispanic patients have worse complications, including CNS infection and renal complications. Here's that paper if anyone would like to reference it. With hypopit, women also have higher mortality as compared with men, and we think this may be related to untreated gonadotropin deficiencies and then higher corticosteroid dosing. And then lastly, I just wanted to mention, and Dr. Limes mentioned this in the chat, which is to really listen to and believe your patients, especially when they're women or people of color, because often we sort of brush off, well, you're fatigued, whatever, but Meryl did a great job, and sounds like the team really went into the history, figured out that she hadn't been having her period for a long time, and to think about these more central causes, and now this person is in a way better state with appropriate treatment. And then, as always, I like to give you some self-directed learning. So I have a picture here. I think it's pretty self-explanatory what that is. And so my question for you to look into is, would you treat the above patient with bromocriptine, with surgery, or with gamma knife? And it is associated with the case today, but sort of the opposite. So I'll let you guys look at that just for a second here. Take a picture of it if you want. I really want to thank our endocrinology experts for being present here. I really appreciate you all being here and walking us through this case. And that's all I have.
And if it's okay, I know we're out of time, but I also wanted to thank the endocrine fellows, because I sent a page out about this case at 5 o'clock on a Saturday, and they called me back. I think, remind me your name, it was Jill, or she was just so excited. I've never seen anyone more stoked to return a page at 5 on a Saturday. She's like, this is awesome. So interesting. Get this and this and this. And she wanted to chat for like a while.
Must have been early in the year.
It was really
Well, thanks for having us, guys. Let us know if you have other cool cases you want to go through or other teaching points.
Absolutely. Thank you so much.
Welcome, applicants. Okay, all right. I'm gonna leave. Bye.
Bye.
Thank you all. That was awesome. Yeah, to the fellows, thanks, our resident discussants, and Sneha, obviously, for pulling together a fantastic case, as always. Thank you so much for doing that. That's great. For the applicants, please hang out for a second here. We'll wrap your day up for you. Meryl, that was a really fun case.
I know, right? It
I
was
know.
so fun. And I was still obsessed with, like, because all those labs take a while to come back. And to Jordan's point,